So thanks to all the faculty for having me. Thanks for inviting me, Steen. I'm going to talk about CT and MR imaging of liver lesions. As Steen said, I'm a HPB radiologist with a bit of EUS and a little bit of intervention, but not a huge amount. So Shelley will cover all the intervention and I'll stay well away from it. Just a bit of background about me and the sort of important factors to consider when looking at HPB imaging. I generally have to say that I find HPB and upper GI surgeons the best of the bunch at knowing their imaging in the first place. I rarely have registrars coming down to me not having looked at imaging before they've come themselves. And second to that, they generally are on the right track with it. So you've obviously got a great background in basic training anyway. The key to understanding all CT and MR cross-sectional imaging of liver is volume, you know. So we're not going to get you to fellowship level radiology in 20 minutes, but I'm hopefully going to show you how I approach CT and MR in a logical way that you can then apply to how you approach it and get a little bit further than you do already. Okay, physics is really important with MR, obviously. Less so, but still with CT, but that's a whole nother lecture and a whole nother set of hours, which will only put us to sleep at this point. So let's forget about physics if we can. So I'm going to show you real cases. I'm not going to give you any clinical context or information, not because I'm a vindictive radiologist sitting in a dark room, but more because I like to look at imaging without bias. So I like to look at the imaging first, make my mind up about what I think is going on, and then add in the clinical information that hopefully then supports what I thought in the first place. If it doesn't, it's left field, and then I need to look again. But I like to approach it from a baseline with no initial bias. I've tried to sort of structure this talk to give you 5 of my top tips for working out what things are. But I'm not going to talk to you a lot about classical versus non-classical features. There's lots of subtleties in liver imaging where we can get mimics of lesions that look like other lesions, and there's subtleties that will help us out. I'll do a bit of that, but that's again is a whole nother volume of discussion. So I'll try and keep away from that to keep to the basics today. Okay, like I said, we'll look at my approach. It's not the way everyone should do it, but it works for me. And it's a logical and safe way to sort of go about things. So if you want to adopt that, great. If not, go for your other way, as long as you can get to the end point in a safe way, okay? Hopefully what I'm going to do is give you a bit of confidence so that you are happy with where you're getting to with imaging. And therefore, after that, you can go to your local radiologist and discuss cases that you think you're not sure about. Because really, that's what your radiologist is for, is to help you out to figure out what something is when you're not quite at the end of the road. So we'll get on with it straight in. So first thing I do when I look at a CT or an MR is set the scene, look at the background liver. What condition is it in? There we go. So you're going to see, hopefully you can all see this case of a CT. We're scrolling through from the top of the liver all the way down. We can see here that there's ascites. We can see that there's lobar redistribution and there's irregular contour to the liver. The portal vein's patent. We can see that there's varices spotted around the abdomen. Okay, so this is clearly a cirrhotic and decompensated patient. When we looked at that liver, there was no big mass that jumped out. Okay, so in the context of this talk, looking for liver lesions, it's difficult. We know that the liver is cirrhotic. We know that the standard CT that we get generally is a portal venous phase. Okay, consider the context. In cirrhosis, we know, okay, that cirrhosis is an unfavorable environment for metastatic disease. You're less likely to get mets in a cirrhotic liver. The contrast phase, like we said, you've got a solitary portal venous phase in the CT. We know that actually the lesions that we're most concerned about in cirrhosis will be seen in an arterial phase. A classical appearance of a HCC, for example, which is the most concerning, and the most common in cirrhosis, is arterial enhancement followed by subsequent washout, either in the portal venous phase or later than that. Okay, your differential though in the context of cirrhosis is immediately narrowed. Okay, here we have the same patient in the arterial phase, and just keep your eye out. I know this is fast but look out for some lesions, okay? Lesions that you think might be something. Again, it's difficult. I'm scrolling fast deliberately. One, because we've got to get through a few cases. Two, because we've got a backlog of scans to report. So this is real time for me now. Laying that out sort of more statically, there were 3 nodules there that I picked up. One here in the left, one here in segment 5, and one here in segment 6. Sorry, further one in 5. Now these are all hypervascular. They're all hypervascular. This is an arterial. These are all arterial phases. What does that mean? Well, okay, we'll go on to characterization a bit later. But in the context of cirrhosis, they're arterializing. On the portal phase, we didn't see them, and I'll reassure you that I didn't see them either when I looked on the portal venous phase, and they weren't really there on a delayed phase. So in this context, these are probably dysplastic nodules, not quite HCC because they don't fulfill the criteria for washout. Okay, is there anything else they could be? Well, yes, of course, always. But what would help us figure that out? Portal vein thrombus, hep vein thrombus, that's always going to push us towards HCC or cholangio. If there's peripheral biliary dilatation next to one of these lesions, then we're going to think more cholangio. Of course, there can be pre-existing liver lesions. So you can get hemangiomas in cirrhosis, you can get FNHs, you can get adenomas, but they're much more rare, okay? And actually at this size, does it really matter? If they're not HCCs, it's not necessarily a problem. Okay, moving on. So after we've set the scene, I then look for the lesions. How do you pick them up? Okay, your CT, you're going to be used to seeing those little hypodense lesions, picking things up in different phases. So I'm not going to show you a CT here, but here's an MR. This is a T2 sequence. And as you can see, this patient looks like they're pretty much doing a dance on the scanner. There's loads of breathing artifact. It's really difficult to know that you've even got enough slices there to cover the entirety of their liver. And that's a common problem. That was a T2. The way you can tell it's a T2 is because the CSF around the spinal cord, which is sort of an easy go-to area, is bright, okay? Here's another T2 of the same patient at the same time. And you can see there's less breathing artifact here. There's less motion. You can see that you're covering the liver much better. It's a different type of T2. And basically with any T2, you can see that the fluid is bright. That means it's a T2. With any T2, your parameters, without going into too much physics, mean that you'll get less motion if you use a shorter sequence. But with a shorter sequence, you're going to get less resolution. Okay, so it's a trade-off between the 2 types of sequences. Either you accept a bit of breathing artifact and a bit of motion, or you accept lower resolution. Either way, on these 2 that we've just been through, I didn't spot any lesions. I'll just run through them again so you can have a look and just see if you can pick up any lesions. I'm not picking anything up on this one, which is the movie T2, but the slightly higher res. And this is the lower res, but less movie. Again, I'm still not picking up any lesions here, all right? Remember that on MR sequences, if a lesion arises from hepatocytes or local tissue, it's less likely to be conspicuous on your standard sequences, okay? If it arises from another type of cell, or it's a different type other than hepatocyte, you may well see it, okay? Your diffusion is the most sensitive sequence overall for picking up any lesion, and in particular the low B value. Now, this is the sequence that you look at and you think that's just a mess, which it is, I completely agree, but it is actually really useful. It's a really sensitive lesion. So I tend to, in non-cirrhotics, go to this diffusion first and look at the low B value and see what's there. If there's nothing on it, I'm already immediately pretty confident that I'm not going to see anything. Now, the 2 images to the right here are the same patient post-contrast. So that's an arterial phase. This is a later phase, a portal venous phase. And you can see that there is a lesion that arterially enhances and washes out. It is there on all those sequences that we've just looked at. And it's big enough that you would think we should see that. But actually remember, this is of hepatocellular origin. Therefore, the diffusion, the T2, is going to look isodense. The contrast is what makes this visible. So in a cirrhotic patient, my tip number 2 is go to the contrast. In a non-cirrhotic patient, my tip is go to the low B value first. Okay, and that's how you're going to pick up lesions. Okay, this is a non-cirrhotic lesion, liver, sorry, and it's that nice high-res T2. The patient's managed to do it without breathing. Okay, again, difficult to see a lesion. Okay, showing that this is a multiple phases of the same patient. And this is arterial phase. I'm still not seeing a lesion very clearly there. I'll let this run through so you can all have a look. And I want you to all have a look to try and pick out a lesion. Okay, portal venous phase. Okay, late phase. And I'm still not seeing anything there. And delayed 5 minutes phase. Okay, this is the delayed 5 minutes, I think. Yeah. And I still didn't see anything. Anyone that did see something, please email me after and we'll offer you a job. This here on the right is a late 20-minute delayed phase in a patient that's been given hepatobiliary contrast. So what that is it's contrast that is picked up by hepatocytes, makes the background parenchyma bright, and therefore any non-hepatocellular lesion looks like a black hole. Okay, so any other lesion that doesn't arise from the liver will look black. And if I point you in the direction, you'll see that somewhere around here, there's a tiny lesion there, which you can then see. And I will, without going back over those previous sequences, you can't see it on the previous. Now, looking at the diffusion, this is a low B value, this is a medium, and this is a high. It's there on all of them, okay? And although this is a horrible looking image, it's very easy to see. So I'm just showing you that example of the B value is really great. The diffusion is the best one sequence for picking up lesions in a non-cirrhotic liver when most of the sequencer might not show it, especially when it's small. Okay, that turned out that was a metastasis, a colorectal metastasis, out of interest. Now, if you Google characterization of liver lesions, you'll get 100 different images like this that show you what things should look like in a T2, an arterial, a portal, and a delayed phase. There's classical patterns, and I'm not going to go over each one to say what, to show you a breadth of lesions. That's freely available online. But actually, these are really useful, okay? So my tip 3 is learn these. These are not, learn the classics, and if something fits into it and it's perfect, great, okay? Here's a CT, we'll have a look the same way, okay? So looking out for liver lesions, this is your standard portal venous phase. Not easy to see. I think I may have seen something there. There was something maybe there, but it's quite washed out. They're not very easy to see. Okay, and there's not much more. We'll take my word for it there. Interesting here is if we look at the MR scan, this is a T1. Remember, look at the CSF around the spinal cord. It's low signal this time. So this is a T1, and these two phases, these two types of acquisitions are in and out of phase. That tells us whether there's fat in the background liver. Now we can see that the signal drops in the out of phase from 300 to 260. That's pretty significant. So there's a fatty liver. Now on CT, what that means is any hypodense lesion might not be easy to see. Okay. The lesion that we've got, the two lesions that we've got in that liver that I did vaguely point out, are these lesions. Is this, well, they're representative here. So here's a T2. Very uniform, lobulated, very easy to draw the edge around. The diffusion, it's there again. The ADC, which is a derivation from the diffusion, and it's bright on that as well. Classically, the hemangiomas will be, okay? Again, contrast phases. With a hemangioma, you want to see very nodular peripheral early enhancement in that arterial phase, and then you want to see it filling in subsequent phases. That's classical. So in this context, absolutely fine. The CT doesn't put me off because it's a fatty liver. That should, if anything, make this lesion more conspicuous because it should be brighter in that portal venous phase. You can see it. It's not great, but the MR is very characteristic. So I'm very happy that that is a hemangioma. Going through the other common lesion, you'd be forgiven for thinking that this MR slice here doesn't really show anything. But actually, you can tell there's something there because the lesion is big, it occupies the left lobe. The architecture is different. The vessels of sort of the branching vessels and ducts that you see in the right lobe, you don't see in this section, and it looks very rounded. Interesting again, though, that this on the diffusion is the same signal. Again, on the ADC, the same signal. That suggests to me that this is hepatocellular in origin, and that's a real good marker for something that it comes from the liver itself. In the non-contrast phase, it's again ISO, okay? Arterial phase, it enhances uniformly and brightly. And this is again that late phase where it retains contrast. In the Hep-Bil phase, it keeps the contrast. And this is very characteristic of an FNH. Sometimes FNH is a bit brighter than this in the Hep-Bil phase. If that was anything but of hepatic origin, that would be like a black hole in that primivis phase, because the rest of the liver would have taken up contrast and left that behind. Okay, so what I'm trying to say here is, if your ducts line up in a row, go ahead and nail it. You've got the diagnosis. If they don't, that's when we've got a problem. So just to summarize, we've got to consider the background context. We've got to think about the background state of the liver, and you've got to pick out that information from what's in front of you. Use the sequences in a sequential way, but know when you've got enough and know when you need some more, okay? Classical features are great. When we Google patterns of enhancement and such like, if it fits to that honestly and well, great. But if you've got non-classical features, always question it. And tip 5, the final tip is, if you get to that point where you've got non-classical features and you're not really sure, you can't finalize it, get a friendly radiologist. That's what we're there for. Okay. Very much. So I will stop sharing.
Well, thank you.
Great, thank you very much.
Yeah, so Adam, you want to take?
Yeah, thanks, Sharon. So I'll just introduce Shelley Chapman. She's our HPB interventional radiologist at Guildford in Surrey. Shelley trained in London, Surrey, and a fellowship abroad. And as Stein was saying, as HPB surgeons, we rely heavily on our diagnosticians and our interventional radiologists. And certainly, Shelley has saved quite a few of my patients. So over to you, Shelley.
Hi, thank you, Adam. Let me just share the screen. So I'm Shelley Chapman. I'm a diagnostic and interventional radiologist at Royal Surrey in Guildford. Today I'm going to be talking to you about intervention in liver surgery, what we do, why we do it, and briefly how we do it. And this is based mainly sort of targeted for surgical trainees. It's going to be about 20 minutes with an opportunity for questions. So what's interventional radiology? It's minimally invasive, image-guided procedures. Often we use the cell dinger technique. We make very small incisions, 2 to 3 millimeters, and that's why sometimes it's described to patients as pinhole surgery. It's radiologists who perform the procedures. We use a variety of image guidance, fluoroscopy, ultrasound, CT, and MR imaging. And we work in a variety of systems: arterial, venous, biliary, luminal, and we also perform biopsies and ablations. So we do lots and lots of drains and tubes. Often these are performed by our diagnostic colleagues actually in several hospitals. So draining liver abscesses, gallbladders, post-surgical fluid or collections. We can upsize drains or manipulate them into a better position. And we also insert NG and NJ tubes if we have to. But the more exciting stuff, arterial embolization. Most of our patients are awake or under conscious sedation. We have femoral, radial, or brachial artery access using 4 to 7 French sheaths. We use, through the sheath, we insert a wire and a catheter, manipulate that into a main vessel, inject iodinated contrast, performing angiography, And then through the macrocatheter, we insert microwires and microcatheters selectively and selectively into the distal vessels. And through the microcatheter, we can deliver a variety of embolics from sort of reversible gel foam to permanent coils, plugs, particles, and we can also deliver chemotherapy and radiotherapy. At the end of the procedure, we either apply manual pressure to the artery or we can use closure devices. And depending on what vessel we use and what closure device, patients can mobilize between 0 to 6 hours. So we can do bland embolization, and this is either with coils, generally to stop bleeding, or with particles. And we can do this preoperatively to reduce tumor vascularity and tumor size, which increases the resectability often of tumors. So this is a patient who had a PVPD, and a few days post-operatively, they presented with signs of bleeding. So they had a CT angiogram. This is the coronal image. And here you can see an abnormality in the left side of the liver. And this is actually pseudoaneurysmal dilatation of the left hepatic artery, which in this patient is arising from the left gastric. So the patient came to the angio suite. We inserted a sheath into the femoral artery, a reverse curved catheter into the celiac axis, and then a microcatheter through that. Injected some contrast and confirmed what the CT showed. And to treat this, we inserted coils firstly into the normal blood vessels, the normal branches off of the pseudoaneurysmal left hepatic artery through the pseudoaneurysmal segment and then into just the proximal part of the artery. And this contrast enhancement at the end showed that there was collateral flow was preserved and the patient recovered fine. We also performed transarterial chemoembolization known as TACE, and this is either drug-eluting beads or chemotherapy mixed with lepiodol into a emulsion and delivered distally in the distal artery supplying intrahepatic tumors. And we can do this to downstage tumors to make them amenable to resection. We also do this in HCC patients as a bridging treatment for patients who are on the liver transplantation list. So this is a patient, an axial CT slice in the arterial phase, and we've learned that HCC is arterialized. So you can see this low density lesion here, which is actually an ablation zone for a previous microwave ablation this patient has received. But unfortunately, down the line, the patient has recurrent HCC outside this ablation zone, and you can see it as arterialized nodularity. So the patient was discussed at the MDT and referred for TACE. So this is the reverse curved catheter in the celiac axis and microcatheter out into the right hepatic artery. And contrast is injected to confirm this arterialized nodularity, which actually looks a larger region than on the CT. So here we gave doxorubicin drug-eluting beads. And this is the before image and this is the after image. So you can see at 6 weeks, there's no longer any arterialized viable disease. And instead you can see a hypo-enhancing region where the treatment was delivered. And this patient remains on the liver transplant list. So we can also perform transarterial radioembolization, this time using beads labeled with a beta emitter called Y90. This time around, it's a 2-stage procedure. The first procedure is to embolize any vessels that we don't want to receive any of the Y90, so commonly the GDA, and also to ensure that measure and ensure that the lung shunt is less than 20%. Obviously, we're restricted in terms of funding and who we can give these treatments to, but often it's for patients with advanced HCC who are Child's Few A, and when other therapies have not been effective. So this is a patient who presented with hemorrhage, and you can see on this coronal CT scan that there's hyperdense abnormality in the pelvis in keeping with blood. And then at the top of the liver here, you can see this large low density abnormality. And this corresponds to this abnormality on the axial slice, and again, a large hypoenhancing lesion in the liver. So the patient came for a transarterial embolization, a bland embolization, to stop the bleeding. So again, a reverse curve catheter into the celiac axis, a contrast injection, and you can see that there's this large lesion here with multiple arteries supplying it. And we injected bland PVA particles to completely obliterate the arterial supply, and the patient had no further bleeding. This image on the left is an axial CT slice a couple of days after the procedure, and you can see a good result, an expected result. So no enhancement or very little enhancement of the lesion that we've targeted, and actually you can see lots of small foci of very low density in keeping with expected sterile necrosis. The patient had a follow-up CT scan 6 to 8 weeks later, and unfortunately, whilst the overall tumour size was smaller, there was still enhancing tissue. So the patient was discussed at the MDT, and for this patient in particular, they were referred for radioembolization, which they had as a two-stage procedure. And on the left, you can see the fusion images of the CT and the SPECT, and you can see lots of uptake, particularly in the solid part of the tumour, and very little in the more cystic part, and nowhere else in the liver. And then this lady has had a very good result, and 2 years down the line, her tumour is still very small and non-viable. So we also do venous embolizations. The main procedure we do for liver surgery is the portal vein embolization, and the idea is to induce hypertrophy of the future liver remnant greater than 25%, assuming that the background liver is normal. So this is performed under conscious sedation. We gain access to the peripheral portal vein branches via ultrasound guided puncture, and then we deliver an embolic into the liver portal vein branches that will be resected. There's a variety of different embolics we can use: particles, coils, and glue. And often our surgical colleagues have preferences about what we use, because obviously they're going to do a resection a few weeks down the line. We insert a gel foam plug to the tract, and some centres, and there's some research ongoing about hepatic vein embolization by a transvagal approach at the same time as the PVE. So this is a typical PVE. On this picture, we have access by the right side of the liver, a catheter coming into the main portal vein, and then contrast has been injected to opacify the portal venous system. And then on this side, you can see the end point. So there's no more opacification of the portal vein branches on the right, but the left is intact. So generally, we image these patients at 3 to 4 weeks. And this is a before image, axial CT in the portal venous phase, and you can see this tumour that the surgeons want to resect, but you can see very small left lateral segments here. And then at 4 weeks, and you can see that the tumour actually has increased in size, but so have the left lateral segments, and this was greater than 25%. So the patient proceeded to liver resection. We perform a lot of biliary interventions. These are always done under conscious sedation. We would prefer some to be under general anaesthetic, pending anaesthetic availability. We perform an ultrasound or a fluoroscopic puncture of the peripheral biliary tree, and then we have a variety of options. We can insert drains, either external drains or internal external drains. We can perform brushings of a stricture for diagnosis, or even forceps biopsies. We can insert stents, so generally plastic stents of a benign disease and metal stents of a malignant disease. Covered stents are often inserted in patients who are going to surgery because they can be more easily removed, whereas uncovered stents are for patients who are having chemotherapy or just palliation. We can even stent the third and fourth parts of the duodenum by the biliary tree. We give or provide access for cholangioscopy and laser lithotripsy of bile duct stones, and we can treat hepatobiliary strictures by performing balloon dilatations. So this is a PTC, so again, access from the right side into a peripheral bile duct, and you can see a very fine radiopaque wire sat here. And then over that, we've inserted a external drain, which is not very radiopaque, but it's curled up here. And crucially, this patient is for an acute Whipple, so we haven't crossed the stricture distally, but this drainage enables the patient to have the bilirubin dropped whilst they're being prepared for surgery. We also treat non-surgical patients with more central lesions. So here you can see bilobe dilatation. So this patient went on to have bilateral access via the left and the right lobes, and then these metal stents placed in a kissing formation to unblock their biliary tree. This patient had an aberrant right posterior sectoral duct injury at a difficult cholecystectomy. They had a hepatobiliary at the time of the surgery and recovered really well, but then represented with recurrent cholangitis. This is a coronal MRCP sequence, and you can see that these ducts are dilated here in the right posterior sectoral duct. And this is in keeping with a stricture. You can also see some filling defects here within the duct. It's a bit more subtle. So the patient came for a PTC, so puncture of the peripheral duct out here, injection of contrast, and then you can quite clearly see some filling defects within the ducts here, just above a tight stricture. So a wire and a catheter were passed through the stricture into the jejunal loop, and then a balloon was placed and inflated across here. And then you can see very prompt flow subsequently into the jejunum. And the patient has been well and hasn't had any further bouts of cholangitis. We also perform microwave ablations of liver lesions. Our preference is that these are under general anaesthetic, but they can be performed under deep sedation. We can do this percutaneously, but we often do and perform microwave ablations intraoperatively, and we can perform biopsies at the same time. It's a simple technique, only requiring one needle, which is passed into the center of the lesion, and then you can adjust the wattage and the timing of the microwave ablation to increase the ablation zones to cover large areas. And generally we're treating lesions around 3 centimeters, but we can go up to 4 centimeters or do multiple burns. So this is an axial MRI scan, and here you can see this lesion, approximately 2 to 3 centimeters in the left lateral segments. It's arterialized and then demonstrates portal venous washout, classical for HCC. This patient wasn't fit for an operation, unfortunately, so was referred for microwave ablation. Here you can see the ultrasound image of the same lesion. A needle was passed in here and a burn was performed. And 2 years and 10 months down the line, there's still this cystic abnormality in the region of the ablation zone, but no evidence of tumor recurrence. So a very good outcome for this patient. However, microwave ablation is not suitable for all patients or all lesions, and we have new technology called irreversible electroporation, also known as nanoknife. And this is non-thermal. Critically, it's non-thermal energy, electrical energy, and it disrupts cell membranes and causes cell death. The good thing is that it retains the structural integrity of other structures such as vessels, the gallbladder, bowel, diaphragm, kidney, so we can target many more lesions. Patients require GA with full paralysis, and multiple needles need to be inserted, unfortunately, between 1 to 2 centimeters apart, and they need to be perfectly parallel. So this is a patient we treated recently, a young patient with melanoma metastases. They had had a previous treatment at a London hospital to a lesion up here, and unfortunately had had a biliary fistula. Because of this, both the surgeons, the radiologists, and the patient were not keen on further sort of microwave intervention. But at that point we had the option of IRE. So the patient was referred for IRE. They also had a second lesion in a tricky spot here next to the gallbladder. So the patient was referred for IRE for both of these lesions. So the IRE needles are very long, up to 20 centimeters. and they need to be obviously inserted so they're not damaging any other structures. Here you've got lung, and so we had to take this angle. Here you can see a volume rendered image of the 4 needles, almost perfectly parallel, passing into the region around this lesion. And then we've got some before and after images. So this is the before lesion of the more cranial, before image of the more cranial lesion, and afterwards at 3 months you can see no lesion. And again, the lesion next to the gallbladder, you can see no lesion there. So a good success, well, short-term success for this patient who's still having follow-up. So take-home messages are that we do a broad spectrum of minimally invasive image-guided procedures. We have a role in the pre, intra, and post-operative settings. Sometimes we're a reasonable alternative, so please consider us. And remember that radiologists are your friends.
Thanks, Shelley. That was perfect. I hope the surgical trainees enjoyed that insight into what interventional radiologists do for liver. Does anyone have any questions on the chat?
I don't think there's many questions in the chat. I don't know. So I don't know if anybody has a question, but otherwise, shall we just kick off some questions, Adams? I mean, I've got a few questions.
Yeah, maybe a question for Sharon and Shelley. What's the most challenging procedure that you do, Sharon, and then Shelley? What do you think? What throughout your training? What's the procedure that took you the longest to master?
I'd probably say it's a procedure that I've left behind me now so much. So it was PTCs, particularly in the less dilated systems. I trained up with that when I was a registrar, and that needle-hand-eye coordination to get into small peripheral ducts, I felt that was difficult. And it's just something you need a lot of practice with. Don't underestimate the skills of the what I call the proper IRs, who do everything, like Shelley, because they'll make what I would potentially take half an hour doing a job of 5 minutes. So you know, in some ways, you know, it's good that I've moved on to EUS a bit more, because the skills that, you know, we were certainly should be suited, and I'm sure you think this in surgery as well. You know, we should sort of place ourselves where we thrive the most. So for me, it was PTCs. I don't know what you think, Shelley.
Well, I actually think nasovaginal tubes are some of the most difficult procedures you can do. But apart from that, proper IR, I would say probably the TIPS is like the most challenging procedures that we can do. The variety of anatomy, occluded veins, different puncture sites, you know, working from the femoral axis and from the top. If there's major hemorrhage going on, then all of those, you know, lots of things to be thinking about, and lots of times you have to sort of iterate and, okay, that approach didn't work, let's try something else, and do we do an ultrasound at the same time? So we're only developing our tip service at the moment, but I remember at the King's doing those. It's, you know, really you really need to have your breakfast and have your thinking cap on to get through those.
I guess, and sort of bleeding from the GDA and things is stressful, and that must be quite difficult to master as well. There is a question from one of the surgical trainees in Bristol, Emily, for Shelley. Are there any size limits on lesions for IRE nanoknife? And how does its effectiveness compare to microwave ablation?
So it's IRE still in the research phase, so it's safe, but we're not completely sure how effective it is. Certainly all of our patients have had good results, but it's still early days on that. Lesion size, so they say around 3 to 4 centimeters. I know that there is some published data where people are putting in more lesions or doing multiple sort of different rows of the needles. So some people have got it up to 5 centimeters, but that's really for sort of advanced, you know, users with lots of experience. And again, we don't have a huge amount of evidence about whether the full zone of the lesion is adequately treated, and follow up on that. But looking forward to results on that.
Do you always do these? How guided do you guide them by CT, by ultrasound? What's your preferred method?
We do them all in the CT scanner, because that's our default approach. But
For both, for IRE and microwave, or only for IRE?
Oh, sorry, for IRE.
Yeah.
So all of them in the CT scanner, because that's the sort of our backup approach. But often it's easier because you're doing intercostal and you need to get multiple needles in the intercostal space. Actually, it's easier to place them under ultrasound guidance. So often it's a combination. And then microwave, my preference is ultrasound, but that's because that's the way I was trained. And I think it's easier, and you can move the probe with the breathing. So I think it's easier to pass the needles in. But you can equally do it under CT with often with a breath hold.
And would you, I mean, sometimes I notice that, all the people going for ablation will get an ultrasound scan and not all the lesions show up an ultrasound scan. Would you then either go for, would you sometimes use contrast guided ultrasound scans, or would you go CT in these kind of situations?
Generally CT.
Yeah. And has contrast enhanced ultrasound have any place in ablation and IRE techniques, you think, or?
Not for me. I think it is helpful. The microbubbles don't last forever. It's great for diagnostic and looking at enhancement patterns and that kind of thing. For the duration of an ablation, I'm not sure it would help me particularly. Yeah.
Yeah, it's something that we've started doing a bit more of, particularly when the liver's fatty. Because like you say, that the fattiness attenuates the beam a lot. The contrast more when you've got the cross section that shows the character. It's more at the time. I mean, I'm being called in a little bit by my IR colleagues sometimes just to localize the lesion a bit. And contrast we find it sort of does work. You're right. It doesn't last long enough for it to be really useful, but once you've got it in your head where it is, it sort of does help a little bit. So it's something that we're trying, but I don't think that's established process.
Sure. Do you want to read out some more Shaq from the chat box, or?
I just have another question.
Excellent.
For starters, I'm just triggered by the take-home message. Radiologists are your friends. So my question: how often are you being treated like people are not your friends? That some sort of unfamiliarity with your profession.
Shelley, you go first on this one.
I honestly don't know, because there's a reason why you've put the statement there. So maybe
well, we're here to help, and that's how we want to be seen by our surgical colleagues.
I think I might be able to. I think an answer to the question might be is that I was taught quite early on in my career as a surgical trainee that when you want to have a scan report or you want something to know about a scan, you go down to radiology, you speak to the radiologist yourself, but you also have a question in your head, look at the scans yourself. So I was told quite early on, even by my surgical consultants when I was a trainee, that look at the scans yourself, know what you want to ask the radiologist, and when you do that and you go down to look at the scan with them together, I've never had a very obstructive radiologist. Well, 95% of them, when you sort of take that approach, because I think radiologists are also people that enjoy that job, and I think if you show them appreciation, then they will do what you like. So yeah, so maybe that's the trick to win your radiologist over.
Yeah, I'll probably explain. The reason I put it in there is because just to encourage people to come down more. It's not necessarily that doesn't come from a negative place in terms of, I don't have bad experiences from people coming down and asking reasonable questions. I want them to do it more, because I'd rather that than have different requests for inappropriate scans. And so it's more to encourage it from my perspective. We don't have I speak for myself. We don't tend to have negative experiences with clinical teams on the wards, for example. It's more that we want more of it.
More business. There's a couple of questions in the chat for Shelley, I guess. Is there any size limit for TACE? And then the second question is, what are your thoughts on bland embolization versus TACE for liver lesions?
So we will embolize most lesions. So we've done 10 and 12 centimeter liver lesions, sometimes even bigger, particularly when they're at risk of hemorrhage or we think they may have hemorrhaged. So we'll definitely do a bland embolization with small particles. We would actually do chemoembolization as well, but sometimes, often they take multiple treatments because you don't want to give a massive embolization in the first instance. So we'll scan them 6 weeks, and then we'll bring them back for another treatment, see how they get on.
So what's the biggest lesion that you've done a TACE on then?
Oh, I think probably about 14 centimeters.
Oh, wow. Okay.
But in stages though, you never know how really they're going to respond to the first one. And it's always it can be a bit disappointing in the first follow-up scan where there's still a lot of viable disease. But I think there is a role. Maybe do a bland one first and then come with chemoembolization later.
Okay, great.
Yeah, I maybe another question for Shelley. So, so obviously you briefly mentioned hepatic vein embolization as well. Obviously, a bit of a new kid on the block for enhancement of future liver remnant. And what's your feeling on that? Is it going to replace? Do you think it's going to replace dual embolization of both the portal vein and hepatic vein? Is it going to replace PV? You think, or is this for a subset of patients? Do you have any experience with that, or any thoughts on that?
We've had a couple of local cases which are in our region who haven't done particularly well. They've progressed very rapidly, and then they haven't ended up having surgery actually. They had, they didn't have the best outcome, but that's just anecdotal. And we know it's safe to perform. I'm looking forward to sort of the outcome of the Dragon 2, which is still recruiting. So yeah, we're open to doing it. It's pretty straightforward. It would be a transjugular approach at the beginning, access into the right hepatic vein, and then probably an amplatzer plug deployed. So pretty straightforward, a little bit more expensive. Patients recover quite quickly and go home the following day. But in terms of is it worth it? I'm not sure yet.
Not sold yet, clearly. Okay.
There's a question message to me. Oh, sorry, go on, Stein.
No, I'm just wondering, Sharon. So the workup sort of, I mean, you spoke a lot about hepatocellular carcinoma, which is pretty great. But so just the most common, obviously, is colorectal liver mets. We see them a lot. Well, I mean, obviously, I think your question is going to be yes, but the workup for all your colorectal liver mets, MRI is a strong place. And what do you feel? What kind of MRI scans would you use in colorectal liver mets as sort of standard in your workup?
Yeah, so I mean, most of these patients come through with an initial CT, don't they?
Yeah.
But there's lots of data out there now that shows that using a hepatocellular contrast agent with MR makes is the best way to pick for lesion conspicuity and to map out distribution. So it's pretty much standard practice in most places now that if you've got colorectal liver mets in particular, Primavist or Multihance are the two that you can use. Most commonly it's Primavist because it's a time saver on the scanner, and Multihance you've got to wait an hour to get that final acquisition. So most places fund Primavist, and in all honesty, I think if you're not using a Hep Bill agent for colorectal liver mets, you don't really know what's there or what's not, what you can't see.
Yeah. And if you could only use one contrast agent, what would it be?
For everything.
Yeah.
So yeah, Primavist. You've got to. I mean, it gives you confounders because you have it uptakes quicker in the liver, so it can confound your dynamic phases because you've at the same time as enhancement in lesions, you've got uptake in the background liver, so it can seesaw the effect that you actually want to see. But as long as you understand that and you know it's happening and you interpret that along with the way you sort of assess it, then it's a pretty good universal thing.
Adam, I think I sort of...
Yeah, there's a question that comes through to me, actually, useful for the trainees. For Sharon and then for Shelley, what are the risks and the percentages they quote for different interventions, for example, EUS?
Yeah.
And then for Shelley, for example, embolization.
Yeah, okay, I'll go first. So for EUS, for our standard EUS, we're talking, the vast majority of our work in EUS here is pancreatic. And the usual is a pancreatic lesion for EUS FNA, maybe a single biliary dilatation where you're maybe doing more work around the ampulla or the pancreatic head. Generally, the risks for those we quote are about 1 in 1,000 for perforation, 1 in 500 for bleeding, a significant bleed that will require embolization or something. and 1 in 300 for pancreatitis, going down to about 1 in 100 if you've had previous pancreatitis before that. So it's pretty safe. It's pretty safe. We very rarely get an issue. Most of the issues we get with the EUS is from the therapeutic side. So doing pseudocysts, variceal embolizations, hepatic access, biliary access, and that sort of thing. But those are known expected risks of pressured systems and what have you.
Just one follow-up question: what's the learning curve for EUSs in both diagnostic and interventional ways?
Sure. So I learned as a radiologist. I'm training a gastroenterologist at the moment, and it's really difficult to sort of pin that down, because for me, the imaging was never the problem. Understanding the image I was looking at was never the problem. Learning the scope technique was my problem. But for the gastroenterologist I'm training now, his scope technique was immediately amazing, but he just didn't know what he was looking at. Now there is sort of, we're close to sort of setting up competencies and a framework within JETS. And at the moment, the thought is that we should be aiming for 400 EUSs in total, of which 80% should be Hep Bil, unless a subset should include FNA. So that's coming at some point. I think that's probably a little bit excessive, because, for example, the gastroenterologist I'm training, he's probably done about 150 at the moment, and he's pretty much there. I mean, you could say that that's because he's really good, or I'm really good, or it could be that you just don't need that many cases. But that's sort of where we're at, in that sort of ballpark.
And where should interest trainees start? What's an ideal starting point?
So as a baseline, JETS accreditation for upper GI scoping is all we specify to start EUS. So the 200 cases of upper GI, and then it's a good place to start.
These are the UK standards, isn't it? JAG accreditation and such. That's
yeah. So there's no. That's the point. There's no official JAG accreditation for EUS. It's, you know, at the moment there's not an official regulation, but we're trying to bring that in a little bit. So, but the difficulty in designing it is the fact that there's surgically trained EUSs, there's gastro trained, and there's radiologists. So trying to find something that everyone agrees on is a little bit difficult.
Another question on the chat. Are surgeons in your units performing intraoperative RFA or microwave ablation as part of combined or liver preserving approaches? Or are you called to theatre to assist in such cases? Do you think surgeons should be performing these procedures, and how should they train to do it? Because that's for Shelley.
Surgeons are not doing it in our centre. I'm doing it, but I'm also trained. I'm happy to train the surgeons to do it. We've got one tomorrow, Adam.
Yes, we do. We do have one tomorrow. Yeah.
So yeah, I'm happy. I'm quite keen to train. I think surgeons should be doing it if they can do it. I think the ultrasound guided technique is obviously a step that they do different types of ultrasound, but not necessarily the sort of ultrasound approach that we're used to. So I think there's a little bit of a learning curve there. But I'm pretty relaxed about it. We're working together most of the time, but we do combination operations often. So I'll get a heads up, and I'll know when the surgeries are happening, and I'll know if I'm going to get called to go and do a microwave.
Cool. I think we skipped over Jeff's question about lung shunting related to the size of the tumor. Is lung shunting related to the size of the tumor, or can you get significant shunting even in smaller tumors?
Both. Yeah, sometimes we get surprised when it's a smaller tumor, and then we've got a significant shunting, but generally more shunting greater the volume of disease.
All right, thanks. Are there any other pending questions at the moment of the participants? Or well, I think we're nearing the end then. Adam, do you have any more things?
No, I think thanks to Sharon and Shelley for great talks. I hope the trainees have learned a lot. I've learned a lot. I think, Stein, you're going to tell us about the next one.
Yeah. Just Chuck, do you have anything to add? Do you want to say anything more, or are you any more questions?
I'm just looking at the stats at the moment, and it actually is quite good. median participant level 40 during the whole hour. So
Great.
this
Well,
is
that's
very,
excellent for the first,
very
one.
successful start. And
Yeah.
of course, everyone needs to be there the next time. So and that's what you're going to tell them, right?
Yeah, well, Sharon and Shelley, and also a big thanks from me. It was really, really very useful for everybody, I think, even for people who've been in the job a bit longer. So the last slide I will show now quickly is indeed as, where am I now? Sorry, I'm just gonna, I feel sometimes.
You're building up tension, right?
Building up tension indeed, yeah. See, I'm very well. After 2 years, I really know how this works, the whole Zoom thing. So basically, I just wanted to show the slide for the next. Oh, why is this not? Okay, it's going really well. Sorry for that, guys.
It's on the 8th of December.
Yeah,
Wednesday, the 8th
excellent.
of December.
Thanks, Adam.
Yeah. I just thought I'd fill in whilst you're filling around.
I'm filling in. There you go. 8th of December. There it is. So it's Guido Torsili from Milan is going to give a talk about intraoperative, ultrasound guided intraoperative liver resections. Basically, he's got I've heard him talk before. He's got a really good talk on how to use the intraoperative ultrasound to sort of do very parenchyma sparing liver resections, skeletonizing vessels. A really interesting talk. And the second talk is about the use of intraoperative ICG, both in sort of assessing the blood supply of the liver and assessing the segments of the liver for your resection, but also sort of basically for planning your resection, but equally for margin assessment in the minimal invasive liver surgery. So these will be 2 talks next month. So please all dial in for that. Adam and myself will be moderating again. We've got 2 expert panelists that day as well. So hopefully I'll see many of you back that time. And thanks everybody for joining. And thanks again to the speakers.
Thanks, everyone. Have a good night.
Thank you. Thank you.
Thanks.
Bye.
Bye.